Hypothyroidism is defined as decreased thyroid hormone synthesis or action, leading to systemic metabolic slowing. Globally, iodine deficiency remains the most common cause, while in iodine-sufficient regions, autoimmune disease dominates. Autoimmune hypothyroidism includes Hashimoto thyroiditis and atrophic thyroiditis with progressive gland destruction. Iatrogenic causes include radioiodine therapy, thyroidectomy, and external neck irradiation. Drugs like amiodarone, lithium, interferon alpha, tyrosine kinase inhibitors, and immune checkpoint inhibitors can induce hypothyroidism. Congenital hypothyroidism occurs in 1 in 2,000 to 4,000 newborns and requires early screening. Causes include thyroid dysgenesis in 65%, dishormonogenesis in 30%, and TSH receptor antibody-mediated disease in 5%. Untreated congenital hypothyroidism leads to prolonged jaundice, hypotonia, macroglossia, umbilical hernia, and delayed bone age. Early levothyroxine treatment at 10 to 15 micrograms per kilogram per day prevents irreversible neurocognitive impairment. Hashimoto disease is more common in females with a 4-to-1 ratio and peak incidence around 60 years. Subclinical hypothyroidism shows elevated TSH with normal free T4 and may progress to overt disease. Autoimmune pathogenesis involves HLA Dr3 Dr4 Dr5 polymorphisms and CTLA4 gene variants. CD8 positive T cells infiltrate thyroid tissue, causing thyrocyte apoptosis through cytokine-mediated injury. Anti-TPO and anti-thyroglobulin antibodies are markers of disease, but not the primary cause of destruction. TSH receptor-blocking antibodies can cause hypothyroidism and even transient neonatal hypothyroidism via placental transfer. Clinical onset is usually insidious, and patients may present late after significant hormonal deficiency. Skin changes include dry, coarse skin, decreased sweating, and non-pitting myxedema due to glycosaminoglycan deposition. Facial features include periorbital puffiness, pale yellow skin, and thinning of lateral eyebrows. Cardiovascular effects include bradycardia, decreased cardiac output, diastolic hypertension, and pericardial effusion in up to 30%. Neuromuscular signs include delayed reflex relaxation, carpal tunnel syndrome, and elevated creatine kinase due to hypothyroid myopathy. Reproductive effects include infertility, menstrual irregularities, and hyperprolactinemia leading to galactorrhea. Laboratory diagnosis of primary hypothyroidism shows elevated TSH with decreased free T4 levels. Subclinical disease shows elevated TSH with normal free T4 requiring clinical correlation and monitoring. Levothyroxine is first-line therapy with full replacement dose of 1.6 micrograms per kilogram per day. Start lower doses in elderly or cardiac patients with 5 to 25 micrograms per day and titrate slowly. TSH should be rechecked after 6 to 8 weeks after any dose adjustment to guide titration. Pregnancy requires increased levothyroxine dose by approximately 30% with TSH target below 2.5 milli-international units per liter. Myxedema coma is a life-threatening emergency with mortality of 20 to 40%, presenting with hypothermia and altered sensorium. Treatment includes IV levothyroxine 200 to 400 micrograms loading dose, followed by maintenance therapy. Add intravenous hydrocortisone 50 milligrams every 6 hours, and consider liothyronine if needed. Supportive care includes ventilation, correction of hyponatremia and hypoglycemia, and avoidance of sedatives. Final clinical takeaway is early diagnosis, appropriate levothyroxine dosing, and emergency recognition of myxedema coma to reduce mortality.